So, good evening, everyone, and thanks for making time to come out and visit with us tonight. This is the Vascular Health Forum, and the Vascular Health Forum was founded about a decade ago to try to meet a need in the medical community that we perceive. It's a nonprofit that is dedicated toward medical education for people who don't spend all their time doing vascular work. So it's people who are seeing it in their practices, but they're not the interventionist, they're not the person who are seeing patients on a day-by-day basis for nothing but vascular disease, so non-vascular surgery. And it was designed to meet a need that there's been a rapid evolution in the way we manage vascular disease, both on the arterial and venous side. And so what I learned in medical school and residency is just to a great extent, not relevant anymore, because we're not treating those patients the same way we used to. When I trained to be a vascular surgeon a couple of years ago, thank you for laughing too loud, everything was maximally invasive. You did an aortic aneurysm, patient was in the ICU for 3 to 5 days, went home in a week or two, and then was sick for, feeling crappy for 6 months. And now we're doing them and they're going home the next morning and feeling pretty good. So that's just a beautiful example of what has changed over the course of my professional career. And it's continuing to change on a regular basis. As many of you know, it's become so minimally invasive that now we're doing a lot of things in the office, in essentially a cath lab, and under local anesthesia with light sedation. And so this process of evolution, this process of innovation, that is making it easier for us to take care of patients, less invasive for the patients, their recoveries are quicker, and we're able to take care of patients who are much older than we could have when we were doing open aneurysm repairs. They just weren't going to take it. It sits up well with our expanding and aging population that you guys probably see every day. So the Vascular Health Forum is designed and created to fill that niche in medical education. It's a CME event, so we'll make sure that you get the information for claiming your CME at the end. And again, I want to thank you. Our first speaker is Dr. Stratton Danes, who many of you probably know, but if you don't, you should, because he's a nice guy. He was my resident way back when. It was about a year ago. And so he's going to talk about something that we started working on over the last couple of years that's been rather exciting and innovative. And that is, did you know that was a vascular problem? And we're going to talk about the treatment using embolization techniques for arthritis of the knee, for uterine fibroids, and some of the problems that we can now do using minimally invasive techniques to maybe help these older patients who otherwise either have nothing or a big operation. So, Stratton, thank you.
So we're going to talk about embolization therapy, but what Paul was talking about, or Dr. Gagne was talking about, was you pointed really hard at it, my work. So today I was doing an old-fashioned surgery, which is called an axe by fem, which when I trained, when Paul was teaching me things, was pretty regular surgery for people that couldn't get a much more invasive surgery, and as I was doing the surgery, I realized that it had been about 4 or 5 years since I had done this type of surgery, because with our stenting techniques and minimally invasive things, there we go. And so it was funny because I did the procedure with one of our junior partners, and she just came from an academic place and where they do all this. I was like, I couldn't remember the last time I had done this procedure. And so we are getting to this point where we're doing so much less invasive stuff, and we're going into different areas now in embolization. And so we're going to talk about embolization, and for you that don't know, embolization, including vessels. We do this, well, we as doctors do it. We have neurosurgeons going in saccular aneurysms or buried aneurysms in the brain. We do it sometimes before aneurysm work. Just some of the techniques and the things that we use actually to treat embolization. Bleeding. If you've ever had patients show up to the emergency room, this is a bleed in the stomach. This is actually a blush of a bleed. And these are the coils that a very nice radiologist dropped in these to stop the bleed, instead of opening people up for, let's say, a bleed in the lower stomach back in the days. We'd actually have to open them up, open the abdomen, open up the duodenum, oversew the bleed site, and close them up, bring them out, and a lot more pain. And this is done, and patients can go with a little stab incision in the groin. So utility, we keep treating so many things now, and everybody's seen it. We're doing laparoscopic, minimally invasive. The benefits to our patients is low morbidity, sometimes short stays, going home the same day, go home maybe the next day. And it works well in getting out of the hospital. And this is what we're doing. So back in the days, I used to do this procedure, uterine artery embolization. People have heard about this for fibroids. Works really, really well to preserve fertility in women that have painful fibroids. The GYNs got back to doing, doing these with the robot, but this is becoming, they're realizing that this actually might be a little better and more beneficial to patients. This is what I used to do a lot of a few years ago. Getting back into it now, but even more treatments that are out there. This was one that I couldn't even believe, that they're actually embolizing for large hemorrhoids. It's probably not something you want to be talking about as we're eating, and then people are treating embolization therapy. This was a wild slide. Scott, my partner, Dr. James, brought this out, where they're embolizing parts of the stomach to help curb obesity. There's actually to keep going on the embolization thing, in Plymouth, the urologist had an outpatient angio suite where they're doing prostatic embolization, which is becoming almost I didn't read up the literature, I ran into one of the urologists. It's for BPH. It's actually one of the first line therapies, and we know how many patients have BPH. And embolization for prostatic, benign prostatic hypertrophy is becoming almost more and more common, as opposed to TERPs and things like that. And it's becoming more and more relevant. And we're realizing that embolization therapy can help a lot more. And so what we're doing a lot of these days in our office is geniculate artery embolization, which if you told me when Paul was training me that I was going to be treating people for osteoarthritis, I'd say he was crazy. But I also am doing catheterization through tibial vessels, which back in the days that we'd be doing a long bypass. So this is the evolution of why we're here. So geniculate arteries, we're talking about osteoarthritis of the knee here, and trying to get people that are in chronic pain away from chronic pain and improving their lives. So osteoarthritis affecting 27 million people in the United States. Of course, this data here might even not be relevant because this is from 2005. Imagine the numbers would be more important. About 40% of the population is going to get some type of arthritis. And we're talking about arthritis, truly, we get people, everybody here, you're getting people that are getting injections, physical therapy, gel injections, steroid injections. Once you start getting debilitating knee discomfort, the only true treatment is actually to do a knee replacement. But as you know, knee replacement is a maximally invasive surgery. And there's a lot of patients that don't want it. They're young, they're like Russ's age, young and vibrant. There are patients that are healthy enough to actually get it, patients that are morbidly obese, COPD, but they're still in pain. And patients that are in pain, especially as the primary care providers here, you know that you don't get tired of it, but you want to make their pain go away, but there's no way to do it sometimes. The shots don't work. They can't lose weight. Part of the reason they can't lose weight is because their knees hurt, so they don't want to walk. So, what can you do for these patients? There's a new thinking in osteoarthritis, wear and tear disease, an old hinge like this, but that there's a huge inflammatory component to arthritis. There's of course loss of cartilage, there's structural modifications, ligament damage and things, but we know that there's an inflammation part, and angiogenesis, which for some of you that don't know this, that means growth of new arteries in this, and these new arteries are growing into the areas, and they do two things. Number one, they start bringing in chemicals, cytokines, inflammatory markers that make the area worse, but they also feed into the new nerves that are growing into that area that then sensation. And it's as simple as that. So this really smart gentleman in Japan came up with this idea. They started treating hemarthrosis for after-knee replacements and to treat the bleeding knees. And what they noticed was that there was less pain in these patients that they were treating. And they said, well, how about if we use this before knee replacements? And so this is where the data came out of, and I don't have to go through all of this, but what it is that we're going to start knocking out the circulation, the little arteries that I can't name as a vascular surgeon. I can name a lot of arteries, but these are arteries you can't name, but these are the microscopic arteries that are feeding areas of pain. And the idea is to do that and hopefully make people feel better. And the data coming out of Japan was very good. And so then they started to look it out here, NYU, which is an okay institution.
That's where we train.
That's where we train. And then this other place uptown, which we don't like to talk about. But again, so it's not something that we're pulling out of anywhere. We're talking about success rate, meaning technical success rate, meaning how we look, how the arteries look when we look at it. But the most important thing, and I'm going to get into the WOMAC scores in a little while, this is a patient-driven evaluation of their pain. And when you get 92% of the patients that are improving with no major adverse events, and patients actually at 2 years not getting total knee replacements, you say, okay, maybe this works. Okay. And again, I went through this already. I kind of jumped ahead in my thinking about the chronic inflammation leading to new arteries growth and nerve irritation and the inflammatory mediators. And if you knock out these arteries, can you actually make things better? Again, now I have to show that I'm actually a vascular surgeon here by showing an artery picture and showing things that really don't matter. But the most thing is that the main artery is not relevant. The main artery, this is the popliteal artery. This is the anterior tibial artery. These are branches that most people, as orthopods, will know these arteries. We're not even talking about any of these arteries, and I'm going to show you some pictures. We're talking about an artery beyond this little point, right in here, and right here, and right here. So arteries that don't matter, they're not going to affect things. They're not going to kill the skin. They're not going to kill the bone. They're not going to kill things. We're trying to quote unquote kill the pain areas. These procedures are done in our OBL, which is our angio suite in our office. Takes about less than an hour. We're trying to knock out a couple of these arteries at least, ideally 3 to 4 of these vessels, but I'll show you some pictures. We bring patients in, we have them do this, it's a subjective exam, WOMAC score. We make sure they actually have osteoarthritis. If they don't have osteoarthritis, we can't make it better. Simple labs, we don't even hold anticoagulation for some of these patients. And we're getting about a 75% rate where patients actually are saying they're just more comfortable. And if you can get a patient with less pain, isn't that a good thing? And with a low risk profile, and that's what we're talking about. So when we do pictures, and I'm gonna show a lot of pictures because it's easier than me talking, we're looking for what I would call a blush area. This is what the popliteal artery looks like. And again, it's very subtle, but you can kind of see right here, there's a little more circulation here, a little more circulation here, a little more circulation here. Here's the joint space right here. And after we inject, these things that we inject, they're called embospheres, but think of them as really, really small particles. They go out into the very, very small vessels. They're what, 200 to 300 nanometers?
Yeah,
I mean, just, and so the idea is, oops, so sorry, is to knock out just at this area. And so sometimes we even mark these patients. Like some of my patients say, you know, I have an extreme amount of medial knee pain and I'm looking even more at the medial component, or lateral knee pain, or superior knee pain, inferior knee pain. And that's how specific we can get sometimes. And you can see, gosh, I really just can't control this well. Again, inflammation, this blush area right here, and that's what we're doing. And we're in the popliteal artery, which is kind of right about here. And we're into these secondary branches, and then we're knocking, it's so subtle, but that's the whole point of this procedure, is we're knocking out this more blood flow than really should be there. So sorry, my glasses are gonna fall off. And again, this is a great procedure because if you've ever had patients after they've actually had the knee replacement and then they come in and they're still in pain and they're like, I had the knee replacement and we can actually do this procedure in people that have had total knees, because again, if we're attacking the inflammatory component of it, you can do that. Again, I stole a lot of these slides from my partner, but again, really hyper areas right here, and then afterwards, it's all gone. These are just different branches, and I don't need to really bore you with where these things are. But even as primary care people, you can kind of see what this does to people. And so, a little things about this, I kept this in just to make it look like I'm smart and using fancy things called like Chikai wires and measurements, but we're working at such small vessels and small catheters, and that's the most important thing, that we're not damaging any vessels that matter, and even if we do this procedure, if they need a total knee replacement, it's actually not contraindicated. So let's say it doesn't work, or in a year or two later, you can still proceed with actually doing a knee replacement. Again, more pictures that, again, I don't know, I probably should have killed some of these, but again, trying to get the patients to a point where they're happy. They're usually in our office for about an hour for the procedure, about 10 to 15 minutes. We hold a little pressure, and about an hour afterwards, they're out the door. They come in, it usually takes us about 15 minutes to prep a patient, an hour to do the procedure, and an hour afterwards. About 3 hours you're talking about they're going out. They get a little ice on the knee. They usually get a little pain, a little increase in the pain afterwards, but we don't usually give narcotics for this. And then we check on them, we have them do these scores afterwards at 1 month, 6 months, and 12 months. But really, who are we looking at? We're looking at patients that are not candidates for knee replacements. We have lots of those patients who don't want a knee replacement. We all know that the typical knee replacement now, even as good as they are, is what, 12 years?
Yeah.
You know, and I've got 55-year-old, you know, of course. You know, my dad waited and waited and waited, was miserable with his knee for years and years and years, and finally got his knee replaced because he wanted one knee replacement. He didn't want to have it done. Should have had it when he was 50, finally had it when he was 70. He's like, I should have had it sooner. But some patients, you're just trying to push it down the line a little, try to buy a few more years and things like that. And then it's the persistent pain after knee replacement, which is a huge thing. So we're talking to the orthopods, we're talking to their pain docs, talking to their PAs about this procedure. But for you guys, these are patients that we want to see. So who's not a candidate for this? If they're already getting a knee replacement, they should get the knee replacement. Patients who failed, who never improved with the genicular artery embolization, it's not worth trying it again. You can't do it in patients with infection, cancer, or people that don't have osteoarthritis. Of course, that's pretty simple. And peripheral vascular disease, they have to have kind of clean arteries, because these arteries, even though we can't really name them, the ones that we knock out, they can be very important in collateral flow in patients, and so we don't want to knock those arteries out. The data coming out of Japan is 3 years later, we can re-intervene, let's say in 3 months, you got some benefit, starts to wear off, we could come back again. But again, this was Scott's, his own personal thing that he gave me. And this is even 3 months ago. They're all saying an improvement, and again, it's not a cure. It is trying to decrease their pain score so that they might not be thinking about it all day long, and they can get through the day without being so miserable. And if you've ever been in chronic pain in your life and somebody can just make it go from an 8 to a 3, it's a great thing. So that's what we're trying to do with this pain. So I put this up because we do have, trying to do CMEs that we're not just making these things up. And again, a lot of this came out of the Japanese data. Very few reinterventions, very low complication rate, really good results in general with this. So the new one, which Jay is here to take, Dr. Phillips is our resident podiatrist, asked us about, and this is actually something because I actually went through this once and it was pretty miserable when I had it. And it's the same idea. We're now thinking about it, haven't done one yet. I still need to read up a little more about it, but it's the same idea. Anybody have plantar fasciitis? Ever? It's one of the most miserable things. You can't walk. The plantar fascia is the fascia that comes off your calcaneus to the tops of the metatarsal heads on the bottom of your foot. It is extreme amount of pain, happens prolonged standing, walking, improper footwear, overworking, being a little big, inflexibility of your posterior calf muscles. Treatments, if you've ever talked to somebody, rest ice, physical therapy, orthotics device, NSAIDs, steroids injections, but still there's about 10 to 15% of patients that don't improve. The treatments for this, Jay, does, some of this, but anytime you're operating on the foot, the vein of foot surgery, as I understand it, my mom needs just one little procedure done on her foot and she needs to be off her foot for 6 weeks. And even that can take even longer to recover. So, that doesn't look like, I don't want to ever have this happen to me. I don't know about you, but this just doesn't look good, especially because this is Jay doing this. And so, anyway, seriously. So again, the same idea with knee and osteoarthritis, plantar fasciitis, is that again, there's this hypervascularity here that's promoting, prolonging, propagating the pain. And if you knock this area out, you might see an improvement in patients. I haven't done one of these patients yet. We're just beginning to think about it, but this is where we're going with embolization and the idea that we could maybe make patients, get them up, get them moving again, and in less pain, is really a great idea. Again, you can see the blush here, you can see the blush here, and the blush is gone. And you're doing this again. For this thing, for this procedure, we can actually access the vessels near the ankle with an even smaller catheter, even less time in the office, and with really great results. And again, the data again, because they had such good data with osteoarthritis, they started to do this in plantar fasciitis. And even here, this is the Journal of Vascular Interventional Radiology, showing a dramatic decrease in pain, faster recovery. You're only off your foot for a few days. Lower risk, because again, we're using a smaller artery, so there's less problems with bleeding, artery injury, and again, not surgical. So again, more data. Again, I don't need to bother you and bore you guys with this stuff. But again, next steps of what we're doing, we had our partner do his first shoulder arthritis, and if you've ever had a friend who's had a shoulder procedure done, they're miserable for a very long period of time. And again, treating shoulders and trying to get people, again, less comfortable before they have to have knee surgery might be the next step of where we go. And I think that is my last slide. Dan is up. Dr. Gorin is coming in, thank you. Dr. Gorin is coming in, he came all the way from Hyannis or Falmouth, great living out.
Exactly.
So could we, let's have, if there's
Oh,
any questions.
questions, I'm
Yeah,
so sorry. I
let's
didn't-
take the opportunity before we move on to the next topic. If anybody has questions, I know the question, that I had is, you mentioned about, recovery, and noticing how much better their pain is. And you would say, in general, for the knees, they're feeling it a month later, 10 months later?
Usually
day-
they're
day-
feeling it at the week out, and if you actually look at their scores, even at 1 month, when we check them in 3 months, they all feel much, and it actually gets better and better over time. We haven't been doing it long enough to see the 2-year data yet, but there's so much.
The literature.
Yes, the literature says that we're doing much better with it in the long run, and so.
And then we say, re-intervention. Re-intervention because it didn't work, or because they need a little bit more?
I think it's because we would re-intervene, let's say at 2 years, if their pain came back, we go back. But if we got some response, again, when we're doing these injections, we're treating to a certain level where we don't want to over-treat, because when we're injecting these beads in, it's a very subtle thing that we don't want to overdo it, because then the chemical could get into skin arteries, nerves, things like that. So if we start seeing patients with a slight improvement, maybe then we said, okay, maybe we just need to be a little more aggressive about things. And so you can go back in and treat those patients, and then those patients that had a really great response, and then they come back, we can actually look at them again down the line too.
But they're coming back in months or years?
Years.
Yeah, that's the big jump forward, is unlike steroid injections or gel injections, which may work for weeks or months and then fail, the Gagne, the embolization procedures seem to be giving patients years of relief.
And that's really those patients that we're hearing about, they're just not, the most of the patients that I've been treating are those patients who they're just who we call their time period from injection or to pain resuming, it's just getting shorter and shorter, where they're just getting more, they're not, the response just isn't there.
Those are the ones that are gonna be-
Then those are the ones then they go to the gel, and then the gel doesn't work, and things like that. And so, I've been really, really happy with our results with this, it's been quite.
I think knee injections are going away. I mean, they're such a temporizing thing. People are going back 4 times a year, and all of the data would say that if you look 2 years out, 85% of the patients that we treat are still realizing benefit from the procedure. That's pretty good. So the durability.
And a lot of the patients have already been identified, their arthritis, maybe seen orthopedists, had x-rays, maybe they had a gel injection that wasn't working, or steroids, and that's where, when they start to fail those more conservative approaches like physical therapy and such, this is where we come in that place between that conservative therapy and the knee replacement. And that's what this was designed for. Yes, ma'am.
Are you mostly getting your referrals right now from ortho or from primary care?
The funny thing is we're seeing more of our patients just by chatting with our patients. We do a lot of our main patients, we talk to. Orthopedics for some of our practices are really good. Pain clinics, some are, but again, that was part of the reason for the talk, was to get people to understand that there is these other options out there for patients, and so.
And what you'll find is, like, for Dan and Hyannis and myself down in Connecticut, our ortho group is on board with this. Because they're seeing patients they don't want to operate on. But not every ortho group is on board with this. Because they haven't quite caught up with the.
We're not stealing patients from them, because what we don't solve is the knee stability and flexibility. We're just treating the pain. And so, if a patient really wants to be super functional, then they're gonna get a knee replacement, and they're gonna invest their time, and they're gonna be a good rehab candidate. But at least where I live in the Cape, I just did a 94-year-old lady today. She wasn't a candidate for knee replacement. She's on chronic narcotics for her knee pain. And, and that's not uncommon. So, I think these are people we can really, really help a lot.
follow-up question, do you anticipate this to be a treatment for like all types of arthritis in joints? Because like you focus, like the last slide was more about like shoulder stuff, but like, I'm thinking like hips and,
Hips are
The
starting.
You know what I
hips,
mean?
I don't, there's no
So,
doubt.
so I'm
There's
thinking
no
like
doubt.
my 90-year-olds that have hip things that I don't
Mhm.
wanna send for replacements.
It's coming. The
Yeah.
anatomy's a little more complicated, but it's definitely,
Yeah, I think-
it's certainly coming. Shoulders are next. And
The
plantar
shoulders are also
fasciitis
super
are all-
complicated,
Yep.
so.
Yeah, the hips would be a nice thing, but.
Yeah.
I think this will evolve over time. There's two prospective randomized trials comparing injection and knee surgery versus embolization.
Yeah.
And that will provide, a lot of these are prospective cohort studies, but there are a couple of randomized studies going on. And we're already seeing literature that's showing other joints that are being evaluated, fasciitis as we talked about.
Yeah.
You know, so all those, my tennis elbow, you can see if that's not going away, you could have an injection to that, you're not doing it. And it's just, it makes perfect sense.
Okay.
And I think it will evolve, and the beauty of it is it's so minimally invasive.
I mean, you always want to be cautious with a thing like this, not to overpromise.
Right.
Right.
But I think all of us have been struck by how well this works. A good friend of mine who practices in another state, just spent a couple weeks fishing with, but he said, Dan, this is the closest thing to black magic I've ever done. It's like, they get people with a cane and I do these procedures and they're going on day hikes and stuff. It's really, can sometimes be pretty remarkable, so
And what the
we're
literature,
excited about it.
and what the literature would say is about an 80% response rate. So it's like everything else in medicine, it's not perfect. But 80% for a 2, 3 or plus year response, that's pretty good
It's hard to beat.
for patients who are disabled.
And you guys currently doing the procedures for the stomach to help?
Oh,
with
no,
the-
we put that up just to kind of be that.
Now was
thing.
doing it.
What?
Yeah, so
I
my
understand.
partner down in Kenneck is doing it.
Oh, really?
Yeah.
Yeah.
Mhm. Yeah, in
Is it
combination
gonna
with,
hate you?
yeah.
Huh?
Ozempic's gonna hate you.
Yeah.
They
Nobody's
do it in
gonna be-
combination
no-
with Ozempic. It's just an adjunct, yeah. Haven't
He's
done it.
really doing this?
Yeah.
Oh, wow.
Yeah.
So we have one of our partners who's in Connecticut is truly an embolization guru, and so he's the one who's cutting edge. I brought that slide up again just to kind of point out about how far embolization has come. It used to be just for bleeds, it used to be just for small aneurysms in the brain, and now look at what we're doing, and so.
All right.
All
Any
right.
other questions?
Jay, did you have a question?
Well, just a comment on plantar fasciitis. That would be a big, having another way to treat heel pain would be great. There is about 10% of people we treat that they don't get better. Most people get better with cortisone shots and we find a mechanical thing. But the surgery is not great. It's kind of barbaric. I don't really like doing it. It's not, it does take 3 to 6 months to really recover
Right.
from it. And this is, that's the niche for the embolization.
I think that's clearly, for me, that's the next one I want to do. So we'll get everything. That's interesting.
So thank you, Stratton.
Yeah, you can pause.
So, in my role as moderator, we introduced Dr. Dan Gorin. Dan finished his training last week, and just kidding. Dan's been practicing on the Cape now for many years, and has been an innovative leader in treating all forms of vascular disease, but particularly in peripheral artery occlusive disease. As you know, when I had dark hair, everything was a bypass or an endarterectomy, and now much of what we do is minimally invasive. And not only are we doing it minimally invasive, but because we're doing this under local anesthesia, we're not doing a lot of this in our office-based cath lab. And Dan was pioneer in the state of Massachusetts for that many years ago, and continues to innovate in that space. So he's going to talk to us tonight about how the world has changed in his professional career and mine, and how that's good for our patients and what we're doing. So thanks, Dan.
Thanks. So yeah, I got asked to pitch in and come in and give a talk on sort of evolution and new techniques in treating peripheral, artery disease and critical limb ischemia, which would be a definition of somebody who has enough peripheral vascular disease that they're at risk of limb loss. That would be critical limb or critical limb threatening ischemia. And when I look at it, the biggest innovation for me is the whole change of kind of becoming minimally invasive and really being able to deliver care in a more patient-centered, more convenient environment out of the hospital. Hospitals are great, and I operate in the hospital all the time. We take call, and I do 80% of the call at our Cape Cod is our group, and the same in Plymouth, and we're operating a ton, but there's also a huge evolution in the kind of care that we've given. If you go back, my dad was an ophthalmologist, and my dad started practice in the late 1960s. And at the time that he started, if you had a cataract operation, you were admitted to the hospital the night before, you had your cataract surgery, and then you spent 1 week of bed rest in the hospital before you were discharged. You guys all refer patients for cataract, maybe some of you have had cataract surgery yourself, and it's very different now, isn't it? I mean, you come in, the cataract surgeon is doing 40 in that day, right? And they're just zipping off 3-minute procedures under local anesthesia, and you can see the next day, and you're back. I was back operating in days after my cataract operation. So that's kind of the evolution that happened to vascular, but it happened quite a bit later. So vascular surgeons, we've always been the people that sort of provide the full spectrum of care of people with peripheral vascular disease. So if you come to see us and you have a problem with your foot, we can manage you conservatively, we can manage your wound, we can do bypass surgeries, now we can do all these minimally invasive things. So the things that have really evolved over the course of my career is, first of all, the development of all of these what we call endovascular or minimally invasive technologies, whereas when I started, we pretty much did everything by making a big incision in your leg and taking the vein out and bypassing around the blockage. And then we have all these techniques to open up the arteries in a minimally invasive way under X-ray guidance. So those things happened first. So what happened to me is when I started at Cape Cod Hospital, and within a year, I was one of the 3 busy surgeons. I had 3 10-hour blocks in the operating room. So 3 days a week, I was there from 7:30 until dinner, and that's what I did. And as things evolved, and all of a sudden we started doing these things under X-ray guidance, and I went down to 1 block in the OR, and I was in the cath lab doing everything. And then we started realizing, geez, we can do all of these procedures. We're doing them in a local anesthesia with a Band-Aid. I don't need an anesthesiologist there. Why do I actually need a hospital? And a lot of people around the country were coming up with this, and they were coming up with this ahead of time. A good friend of mine, Sam Ahn, who's at UCLA in California, started this first. And this was in about 2004, 2006, where he said, I think I can do an angioplasty of a blockage of the artery in my office. I don't need the hospital. And he started doing that. So groups of people started doing that enough that Medicare turned around and recognized, okay, this is a procedure that can be done out of the hospital, and we have enough data to say that it's safe. We'll start paying for it. And that was at the time where they started to reimburse us so that we could actually hire people to help us and get us C-arm in a cath lab, that we were able to sort of take off and start offering these care in this way. So this evolution of, for me, of becoming minimally invasive kind of happened in stages. So I started at Cape in about 2000. And at that time, I was a young vascular surgeon, and you come in and people say, well, you see people with varicose veins, and vascular surgeons, other than Paul Gagne, hated venous disease, because the only thing you could do was vein stripping, which was really a crummy operation. And they had vein ulcers and all of this stuff. But I was a new vascular surgeon, and I was like, sure, I'll see these patients. And early on, some minimally invasive stuff started to happen, where we could, rather than stripping the vein, which means you put a little catheter up, make an incision here and here, hand the end of the stripper to the medical student, duck, and have them pull, and you basically rip the vein out of the leg. So instead, we were able to ablate the vein under ultrasound guidance with a little catheter that we could put in. So I started doing these in the hospital, and they would sedate the patients, and the patients would get a little confused, and they'd try to climb off the table and so on. And then reimbursement changed, and they said, we don't want you to do this in the hospital anymore. We won't pay you. But we'll pay you if you're willing to do it in your office. And we'll pay you to cover the cost of all the equipment. So in 2005, we started doing that. And as soon as I did my first one, I said, why in the world did I ever do this in the hospital? The patient hated it. They needed an IV. They had to fast overnight. It was all of this rigmarole. And I would go in and treat them in 10 minutes with a Band-Aid, and they walk out with a smile on their face, and they love it. So we started doing all these minimally invasive vein things back, and that was like 20 some odd years ago. So from that, we started looking at our dialysis patients, which is another big thing that vascular surgeons do. We maintain the dialysis access for patients. There's a huge push called Fistula First initiative that they realized quite a while ago that patients, if they get a fistula made out of their own vein, do better. And every way you can, even if you look at mortality, life expectancy, everything, if they get a vein fistula, they do better, and they're also much more durable. They don't show up on Friday with a clotted graft in their arm. So the techniques that we do is to create these fistulas, and then they're smaller veins, and over time we'll do what's called a fistulagram. It's like an angiogram, but we put the catheter in the fistula. do some contrast, and then we use balloons to stretch the vein to get it to the point where you can use. Well, in around 2010 or something, Medicare started saying that they would reimburse to do this in an office-based lab. I didn't have a C-arm, an X-ray, or any of this stuff, but we've been doing all of these vein procedures under ultrasound guidance, and we said, well, when we can see the fistula right under ultrasound, maybe we can just do it that way. So we started trying to do that, and it worked really quite well. And you can see pictures of this where you can go in and here's a fistula, and you can see the balloon catheter in. That's the balloon being blown up around the narrowing, and you can see the narrowing pop open. And that's a nice big forearm fistula that we created doing this under local anesthesia in the office with just an ultrasound machine and a couple of catheters. And we actually quite a while ago published this in the Journal of Vascular Surgery. And if you look at our ability to take a small non-usable vein and turn it into a usable fistula, we had a 93% overall patency. 85% of unusable veins that we had were converted to usable fistulas, and we only had about 11% complications. We had 3 fistulas thrombosed that were just not going to be salvageable. We had nobody that had to be hospitalized, no serious complications. We used what's called tumescent anesthesia, which is what we use for veins. It's a very dilute local anesthetic, and we can actually inject it along the fistula under ultrasound guidance, so that if you look at these procedures done in the office, in the hospital, they will typically fast them, they'll put an IV in them, they'll give them fentanyl to sedate them, and then they'll blow up the balloon, which hurts like the Bee Geeses. And the patient yells, but they can't remember it. And it's a little traumatic for everybody. When we do it in the office, they have breakfast, they come in, they don't need any sedation. And under ultrasound guidance, we put tumescent anesthesia along the fistula. We can really aggressively balloon dilate it while we listen to music and chat, and it doesn't hurt. So the patients very much prefer to have their care in this way. It's much more convenient and so on. So I went through all of that, and then there started to be discussions about, can we just treat arterial disease rather than doing a fem-pot distal bypass? Can we put a stent in the femoral artery in the office? That seemed to be a much bigger order of magnitude. At the time, at least in Massachusetts, all patients who had peripheral angioplasty were admitted overnight. Part of that was because Medicare would pay hospitals, so they all wanted them admitted, but it was just routine, and they were all, at Mass General at the time that I started this, every single patient who had an angiogram or an intervention had 8 hours of bed rest, were watched overnight and discharged in the morning. So I was like, can I do this safely? One, a lot of patients were doing it with anesthesia. Can I do it comfortably? Are the patients going to be okay? And then if I do all of this and I invest all of the stuff in building a cath lab in my office, am I going to go bankrupt and be starving down the street or not? So we started looking at this. So first of all, is it safe? So, and the short answer is yes. These are some early trials that are big series. This is a small community of all of us who started doing this, and Paul is good friends with Sam Ahn, and Bill Julian is an interventional radiologist in Florida, who started cath lab. Chris Lazar's in Tennessee, who Joe Kawadi was with. But anyway, if you look at these numbers, 3,000, 1,100, 2,100 patients, you're talking about complication rates that are minuscule, in the 1% or less range. Patients well under 1% have to be hospitalized and watched for any problem, and mortality 0, 0, 0. So the short answer is, this got put to rest pretty quickly. We can treat these patients very safely out of the hospital, safer than pretty much anything that you can think of. You are as likely to go to the hospital if you walk into my office and just come for a consult for your peripheral vascular disease, and we walk in and find out you've been having chest pain for 2 hours, than you are when you've been monitored and cared for. So that was done. So what are the benefits? Well, one, patient comfort and satisfaction. I love this story that a friend of mine who started one of these labs, and one of his early patients went in and they asked him, what did you think of this procedure? He said, Joe, this is the first time somebody didn't ask me my damn name and date of birth 8 times before I had anything done. So we come and we know them, it's easy, they see the nurse that they already know. And these are all 80-year-old patients, they can't see well, driving's hard, they don't want to go after night, and this is very much low stress compared to what they've done. It's a lot less costly. We cost like 1/3 of what it costs for these patients to have them done. It frees, our hospitals are overwhelmingly stressed. All of our hospitals are having trouble just keeping up with the OR volume that they have. And so if we can take stuff out and free that up for the orthopedic procedure that needs to be done and the general surgery procedure that needs to be done, it's a benefit across the board. And the other big thing for me is access to care, which is the biggest thing for our patients who have chronic disease, Okay, so we're never gonna cure their peripheral vascular disease. Our goal is to be their lifelong vascular surgeon and have them pass peacefully away at 103 with 2 legs. That's what we want them to do. And as I said, our patients they don't wanna go to the hospital, they don't like it, they are a lot less mobile. You think about a patient and they've got oxygen in a wheelchair, and now they park in a parking garage or whatever away and go into admitting and find out what their name and date of birth is, and then they have to go to, and it's just a horrible deal for them as opposed to just popping in the hospital. This is very striking data to me, and it's now about 20 years old, but I don't believe that it's really changed. This looks at patients, according to Medicare data, 20,000 patients around the country who underwent a major amputation of the leg above or below the knee. And it looked at the percentage of those patients that had any kind of vascular treatment before they had their leg cut off. And the answer is 54% of patients in the United States who have their leg cut off never had a vascular evaluation or treatment. They just had an amputation. If you go to Mississippi, pop that number up over 90%. Okay? So there's a lot of socioeconomic issues in terms of access to care. That's terrible care. I mean, only 17% of patients across the board in the United States 20 years ago had an angiogram and intervention before their leg was cut off, and overwhelmingly people have amputations because of vascular disease.
And I think this is a really key point because this has become such a big problem, pointed out, as Dan said a long time ago, and persists, that the policymakers in Washington have gone through hoops to encourage early evaluation with angiography by recommending it, guidelines, reimbursement. It's really like nobody who's gonna lose their leg should lose their leg without having their blood vessels assessed, because the overwhelming primary cause, as Dan's pointing out, is vascular disease. And it's a shame that you wouldn't give them a chance to save their leg.
Yeah, and this is overwhelmingly an access to care problem. That's what it is. One, I mean, we don't have enough vascular surgeons and so on, so we're trying, we're working hard. But the other thing is just, you know the patients that you've seen with bad vascular disease and amputees, they also have a lot of socioeconomics overlays, right? That makes it even hard for them to get there. So the whole goal around office-based care is bring the care. You don't have to go spoke and hub into the big tertiary center in the middle of a city. We bring the care to the community where you live, because it's longitudinal care. We're gonna care for your lifetime, and you need to be able to get there. So, for me, when I started, I used to be Southeastern Vascular, and it was me as the vascular surgeon. And we started a 2-year process to figure this out, because nobody had done it in Massachusetts at all. And Massachusetts is a very hierarchical thing, a lot of academic medicine. We knew that it would be a big target on our back when we did this, because it was kind of outside of the envelope. I partnered with a friend of mine who's over in Fall River, who's a vascular surgeon who wanted to do this. So we spent 2 years visiting some centers around the country and other parts where this was starting to happen. And then we sat down and we basically jointly developed how we were going to develop them. So we said, okay, let's figure out our policies and procedures. How are we going to staff them? Let's do our QA together, all of that stuff. We also made sure that we were certified as centers by Quad ASF, which is one of the agencies that is recognized by the state of Massachusetts for certifying surgery centers, endoscopy centers, and so on. So we made sure that even though that wasn't fully required, our bar was high in making sure that this was a really safe place to have care. This is the center of Hyannis when we started, so it looks like a hospital. I mean, you go in, it's a cath lab. We have boom-mounted monitors, we have a really high-end C-arm that's motorized. We can basically have technology. In all honesty, Stratton has better technology in his OBL than they have it at the hospital. He just does. He has intravascular ultrasound, he has atherectomy, and things that they just don't have. And that's really common with a lot of our sites, that because we're focusing on this and we know the tools that we want and need, and we get them. So we have a full complement. We use ultrasound always to put a catheter, to put a needle in any artery. Nothing's ever done blindly. We use what's called a closure device when we go into major arteries, so that rather than pulling out the catheter and having somebody smush on their groin for 20 minutes, which patients overwhelmingly say is the most painful part of their procedure, we have these little closure devices that we can put in that close the hole so that patients can get up and get out very, very quickly with really no discomfort. We have a beautiful nursing station. We have all of our patient rooms that they can stay in. When I built this, originally, I thought that patients were going to stay 3 or 4 hours after their their procedure because that was really fast compared to the hospital. They now go home in a half an hour, so we've really moved that along. As I say, we treat venous disease, which Paul is going to talk about a lot, so I'm not going to dwell on that. We treat a whole spectrum of arterial disease here, including patients who have what's called disabled claudication or pain in their legs with walking. We treat a whole variety of what I describe as critical limb-threatening ischemia. Those are patients who either have rest pain, so their ischemia is so bad that their foot kind of falls asleep and hurts at night because they're just not getting enough blood there. They have ulcers or non-healing wounds. Those are all we consider limb-threatening. And if we don't treat them, a high percentage of patients will go into amputation. And we treat everything from, blockages down below the knee into the foot and blockages up in the abdomen and the pelvis. And we can do all of that. We have just a whole spectrum of technologies from angioplasty balloons, stents to hold the vessels open, atherectomy catheters. We have a variety of those that are designed to shave away at the artery and soften it up so that we can then stretch it out to a good size and put a stent in, and those work well. I'm going to talk a little bit more about some of the other things that we've evolved in. Thrombectomy is another one where we have catheters that can suck acute clot out of an artery if it's blocked up more acutely, and that works great as well. This is my first early data, and that was just from our first year in 2015, or actually we started in 2013. But this was data in 2015 of 126 procedures, and basically we had 92% of our folks out within 3 hours of the procedure, 98% had successful closure devices, 70% of patients said that their pain scale for the procedure was 0, and I will tell you that I give IV sedation on maybe a quarter of my patients. And I only give it if they have rest pain in their foot or they have pain in their back from bad back pain and they're lying on the darn table for a little while. And that 61% with no IV sedation is now a lot higher as we've continued to evolve. At that time, we had 4 complications, 4%, 5 patients who had hematomas that we watched. Nobody went to the hospital, no mortalities, and all patients we check with ultrasound before they go home to make sure that they're perfect. And if you look at the expansion now with the Vascular Care Group, which is our larger group now, with offices throughout both this state as well as in Connecticut and Maine, we've done over 9,000 procedures with similar results like this. So we've kind of taken this from a concept of, yeah, we can treat some patients to the fact that we can broadly treat patients very safely and well. And just briefly, our Vascular Care Group that we talked about, which was founded in 2020 with the idea that, geez, this is a great way, can we band together a bunch of vascular surgeons that really want to go into communities and deliver great care. And from 2000, we've grown to 21 vascular surgeons, 11 advanced practice practitioners. We're in 14 offices around 3 states. We are physician-led. We are not led by a corporate office. The doctors drive the bus and how we take care of patients. That's one of the things that we really, really value about it. So just a couple of quick pictures and some angiograms of stuff that we do. This is a patient who showed up with an ulcer on their foot, and they had, there's the laser pointer, hot damn. So this is the common femoral artery where you feel the pulse in the groin. That's what's called the deep femoral artery, which is goes down to the thigh, and you can see that there's a missing artery there, and that's a superficial femoral artery which will go through the thigh and down to the knee, and that is after going across and doing atherectomy and angioplasty. You can see a nice wide open artery that we did there. This is a patient who had a full vein bypass for a popliteal artery aneurysm right here. And when we do bypasses or interventions, we follow them along because we know that the natural history of this disease is going to come back. And we don't want patients to show up with a dead foot. So this patient, we followed along and said, gee, the flow through the graft isn't any good anymore. And by ultrasound, we see a narrowing right there. And this big humping calcium that had grown over the top of the bypass. So we found that by ultrasound, took the patient, did again a little atherectomy catheter. Rotational atherectomy is one of the types that we use. It's like a very fancy rotor-rooter, and it spins around and just shaves around the plaque, and then we can use a balloon very gently at low pressure. And there you go, there's a nice wide open artery with great flow through again. And lastly, this is a patient who had a diabetic, they had a foot ulcer, rest pain, and this is the popliteal artery. So this is the knee. So there's this popliteal artery that's occluded right through here. And we were looking across that with a catheter. Again, we did rotational atherectomy on this one. And then low pressure balloon, there's the balloon inflated in the artery there. And boom, there's a nice wide open flow right there to the foot to allow to heal their ulcer. So what has happened since I started doing this? Well, there's a variety of things that we've done because we keep getting better and better at how can we make our procedures safer, less invasive, and more effective. One of the things that we've really leaned to do is what we call alternative access. So traditionally when we started, everybody put a catheter into the femoral artery right in the groin, the big artery there, and that's how you got everywhere. Usually what we call up and over, so you would go up into the belly, take the catheter around the top and go down the other leg. Great way to get everywhere, but it involves time. You have to do more contrast and imaging because you got to get the catheter all the way around. And if you bleed from this artery, you can get sick. Particularly if you come a little bit high on the artery and it bleeds back into the retroperitoneum in the belly, and people can die from that. That's a really dreadful complication. So what we've learned is we don't have to do that. We do a lot of what we call pedal access. We go into the dorsalis pedis or the posterior tibial at the ankle, and we can go back up. Nobody bleeds to death from that. You can stop bleeding with that with your finger. So now we can go up, and also we can cross blockages a lot more effectively sometimes. So we do a lot of pedal access now. We put a little catheter in the ankle. We go up, when we're done, they get a Band-Aid in their ankle, and 20 minutes later they go home. Another thing that we'll do is superficial femoral artery access, which we used to be told you should never do because you can't compress it and it's in the middle of the thigh. Well, under ultrasound, we can go in that artery and go down. It's our preferred access for acute artery embolization as well. And with these little closure devices, we can close the artery. We ultrasound it. Within 30 minutes, the patient's up and walking and they're home in less than an hour. So with that, that's been a real change for us with both the closure devices and the quick mobilization, alternative access. We've gotten really good at limiting sedation. What do? We give oral anxiolytics ahead of time. So my patient takes 10 milligrams of Valium, 25 of Benadryl. Usually, if you're a little old, we tailor that down. And they get nice and comfy and happy, and they go in. We have an IV in. We rarely give IV sedation of any kind. We do ultrasound guided local. So I'm going to go in an artery. I give you local on the skin. I can see the artery, and I put local right around the artery. So my access is painless. And that's really the only thing that really hurts. And then the other thing is our nurses are really great at what I would call non-pharmacological treatment of anxiety. Talk to the patient. That really works awfully well. One of the most important medical devices that I have in my office is a Sonos sound system, so that we play music all the time. The patients can either snooze or they can watch on TV and see what we're doing, and that all makes them able to go through these procedures without having to just snow them with fentanyl and Versed and all of this stuff. We have another technique, intravascular ultrasound, that we've leaned into regularly, and that is an ultrasound catheter. And Paul will talk a lot more about this with venous disease, but briefly it lets us look at the inside of the artery really accurately with an ultrasound catheter. So we can pick up blockages we used to not be able to see. We can make sure the results of our procedures are good. And we can also do it with that IV contrast, which means that if patients have renal failure and so on, we can really limit it. We were faced with a dire shortage of contrast about a year ago. Hospitals were shutting down, they weren't doing CAT scans and so on. We were able to keep going because we really leaned on minimizing our contrast, using intravascular ultrasound, and we were able to keep treating patients by doing this. And another quick thing, and how it is in our practice, is something that Paul actually started for us called Vascular Breakthroughs, and that is a clinical research organization for us that actually lets us partner with industry, and we do clinical trials. And we're very, very active and busy in bringing new technology in, but in a very responsible way where we're tracking our data and so on, and it gives us access to all kinds of new techniques that we're able to do in the office-based lab as well. So that's basically the short story that I have. I'm happy to answer any questions. I always like ending with that slide. So.
Thanks, Dan. That's great. Any questions for Dan? You want those muscles? You can try them. Question? So, you got to switch over.
Yes.
So Dr. Phillips is, as Dan said, a podiatrist who works very closely with our vascular surgeons, and he is going to talk about the other part of limb salvage. Dan talked about revascularization. He's going to talk a little bit about the nasty feet that he has to salvage, and so people can walk. Nothing's worse than to do a major amputation and somebody wants to get up in the middle of the night to go to the bathroom and they got to look around for their leg. It's just a terrible thing. And Jay solves that problem for many people. So,
All right, good, thanks.
take it away.
So sorry for that delay. So basically, the bottom line is we're trying to, the big picture here, we're trying to save limbs. in the literature, at least I think it's a low number, but 150,000 people lose their legs to non-traumatic amputations each year. And that we know also from literature that there's an increased risk of mortality in the first year. There's a woman from my residency that lost one leg a month after that, not too long after that, she lost her other leg and she passed away about 2 months later. So it's pretty serious stuff when we're dealing with ulcers, infections, foot, and avascular diabetic foot that can really lead to these things. So there's a real need for this. Also, the literature, when I reviewed this over the past week or so, there definitely was the amputation rate has definitely decreased a lot since the 90s, and one of the reasons given in the literature is the advent from vascular surgery and bypass open surgeries to endovascular, and also improve wound care and wound care clinics, things like that. Well,
You got it. So there's a lot.
So this lecture is somewhat more about the surgical planning, because usually what happens in our practice frequently is somebody will come in with an infected ulcer that has a vascular component that's not going to heal. That it goes to the vascular surgeons. The vascular surgeons in our practice, they fix that with either in the office or in some cases a bypass, and then it comes back to me. So this is surgical planning, and a lot of surgical planning. Some of this is the patient's goal. Sometimes some patients come in that have this problem with ulcers for a long time, and they want an amputation. Or even sometimes if they even after we talk about everything, they say I want a bone knee amputation. Also some of the sort of planning has to do with strength and revascularization. Sometimes the revasculation's good, but because of diabetes and because of the smaller vessels in the lower leg, there's a tendency for blockage in the lower leg and foot arteries that sometimes they're not really the vascular intervention helps, but it's somewhat tenuous, and so that means to me that if we're going to do something, we do something quick, and we can do something very definitive. Also, other planning is how we deal with these wounds. We let the open wound, we just clean it up and let it heal secondarily, or we use a wound vac to help that because if there's a large open wound, or what we prefer to do if there's enough skin there to close it. If we remove some bone or whatever, we can close it, because in the avascular foot, even after vascularization, sometimes these wounds can dry out and not be as viable. Also, I look at the balanced forefoot. This is for example, this is a guy that I'm dealing with right now, who had a fifth-grade amputation about 6 months ago down in Florida. Recently in Florida, had a first-grade amputation, and he kind of shows up in Cape Cod with his family. And he was told down in Florida that they could make a prosthetic big toe that would work as well as a regular toe, but that hasn't been figured out yet. But so that's not real. So what's real here is generally the literature says that if you're taking two rays out, two toe segments, and all your weight's going to go on 3, that the chances of that causing ulceration or other problems is real. This is a patient that I've talked about. This is a patient that I've talked about doing a transmetatarsal amputation. This is a big open wound right here. This bone is exposed. He's actually going for revascularization next week with you.
Oh, okay.
And then number one, that's done. We're just tasting. They don't bring him to the hospital. Do transmetatarsal amputation. Use a flap on the bottom to cover the area. Those are the kind of things we think about. Quantum or a tight heel torque could be a problem with after TMA or some plantar ulcers. And so sometimes we release the tendinal Achilles or do a gastroc release. And I also look at patients whether they're braceable or not, or things we can do surgically to make a brace fit better, and we can get a wound to fit better. So management includes, I broke it down into gangrenous toes and forefoot, ulcers and wounds, and a case of trauma. This is kind of a typical wound that a vascular wound that we're dealing with. This person has had intervention. The wound is slowly healing with time. This is not at this stage. This is not being treated surgically at all. I'm just watching this. I'm seeing it every week or two. We used sample for. We started with sample, then went to Metahoney, and it's basically local care, and it's slowly healing with debridements. If this doesn't heal or goes the other way, then this would be a partial. The next step would be a partial Alex amputation. But this woman is 89 years old, and we're just trying to heal this without doing that. This is a typical typical case of gangrene of the toes. This is pretty straightforward. The reason for this was pain. She'd been recently revascularized. She's about 82 years old. I think the revascularization had been, and it's not uncommon for after revascularization, but pain to get a little worse in the isolated area that was a problem. We just did a simple amputation in this particular case. We did a racket type incision or a circumferential on the base of the toe, and we went around the fifth MPJ and did a partial med head just to make sure this thing heals. The key with this type of surgery is the amputation surgery. We don't want any tension. If we can help it, no tension. Getting nice full thickness dissection and then closure, either closure without tension. And that's what that is there. That person's doing well. And there's another patient that I parallel this with that had a ischemic area at the PIPJ, the joint of the toe. The toe head was viable, but there was she had been told previously that she needed to have the toe amputated once we did the bypass, did the vascular intervention. And then that person, because the revascularization was so good and not very clean, the joint we were able to save the toe. And this is a woman that she was 86 and likes to wear sandals on the beach and was really emotionally causing problems. So there's decision making done. We don't always just remove the toe. We do them, we can't not do that. The transmetatarsal amputation involves some at times, because of the deformity, because of what might have happened, every case we deal with like this is different. And it's ulcers are in different areas, and sometimes tendons on one side have been released or are dead, and so we have to do some transfer of tendons and lengthening. So there's always a discussion about, there's frequently discussion about muscle tendon imbalance. This is a typical TMA that also was redone because we also had, I did have my original collection that kind of got lost. I did have a picture of a perfect TMA. And I remember in school when we learned about transmetatarsal amputations, how it looked very simple. You just take you take the toes off, and there's a nice big flap in the bottom. You flap over, and you sew it up nice, and it's great. Well, in podiatry, we always have. They didn't tell you about all these ulcers that are open and infected, and the skin is all. And usually we have to. It's usually a arts and crafts kind of thing. You'll see how quick one case of that. This is just a TMA complication. The TMA was good, but then with the splinter, the way issues was sitting, became necrotic, and we went back in and excised that, and we have to rotate the flap back over. This is a patient that's given the ER with a necrotizing type infection, ended up removing the toes and controlling the infection, and then this is a pre-op, you see the gas in the toes here. Just went right to the OR, any kind of necrotizing vasculitis or necrotizing infection generally goes to the OR ASAP, so it's emergency. We moved the toes and did an emergency TMA. We kept the hallux because there was a large wound. We had to open up the whole body. It was going up the long flexors. So we kept the hallux as skin. In some of these more difficult, challenging cases, you need to maintain as much. You need to keep as much skin as possible. And so we were able to have it. That's the flap. We opened it up and let it rest for a few days, and then went back in. And we were showing. And we brought that skin there is the top of the great toe. Brought that down. This was actually presented at our ACFAS meeting or annual Church meeting. I don't have the final post up of it either, but it did heal. These are the kind of teammates that we tend to have in our meetings. Management. Let me see if this will work. There we go.
You trying to play something?
Yeah. We're trying to. Yep. Use the mouse if you want. So this is a typical way that we clean a wound in the OR. This is the cubis. We do this is what we do for most wounds, diabetic wounds or avascular wounds. It's definitely different with an avascular wound. In some vascular wounds that are not they're still not 100% when I do this, but we do this. We use this is called post-lavage, where we use a few liters of saline, clean the wounds, and then after that we do a wound vac or a closure. And this is very typical for all the wounds that we use and that we work with in the OR. So for ulcers that have debridement wound care, the wound vac we use a great deal, and offloading techniques such as padding and casting. In a vascular patient, we would not use a total contact cast because of the vascular complications. And then we use a variety of skin grafting, but both skin grafts as well as commercial skin grafts. And then one big thing we always tend to look at is what caused the wound. I'll show some pictures of that. About one of the things that causes wounds and how we deal with that. And this is the wound vac we use for some patients. What a wound vac is a vacuum-assisted closure where we use negative pressure to basically. I always look at cleaning the wound. We're basically bringing in inflammatory cells to get rid of the product, a vascular non-viable tissue, and promote granulation tissue. This has been around for about 20 years or so, and it's gotten better over time. Right now we use it for this. This is a patient of mine from Nantucket who had osteomyelitis, and it was not getting better. We rejected that and then cleaned out with wound vac. This particular person doesn't have a vascular situation as of yet. This is a patient that I've known for many years. This is a 40. This time he was 45 years old. Came in with also a necrotizing infection. You see some blistering, and that's, and there's gas here on the, gas seen on the MRI. I don't know why we wasted time with that. Here we or right away, here we see the ischemic second toe, so we essentially debrided that, and these are kind of gross pictures, but. So we excise the second toe, and then over time, so being used with a wound vac. This is weekly debridement, wound vac, and in the end, it really came around. There was somewhere in there was if I remember, this is actually 15 years ago, there was a vascular intervention as well, and that's where you want, that's nice granulation tissue, and a good save, and then so he has 4 ways that are going quite well, and this was a skin graft put on there, and this was actually 15 years ago. This was the guy, he sent me pictures yesterday, and that's him too. So he still has a foot, and that's a case of some of these cases are cases that back 20 years ago would have been amputation of the leg without question. So this is that, and then hammer toes or ulcerations. You get these on the top of the toes, the tip of the toes. You just the types of hammer toes, and the hammer toes are caused from a imbalance of the tendons going to the toes. And as you get older, the extension tendons, when you bring the toes up, many times don't lose their advantage or are not as strong, and flexors take over, and so you get these, you get a hammer toe, and if someone has neuropathy, if someone has vascular disease, you can get into real trouble if you end up jeopardizing your toe. These are just the different types of hammer toes. This is a distal tip ulceration that is quite it's quite easy to fix. I remember when I was in St. Elizabeth many years ago, in the wound care center, there was wound care center went into the HBO, and they very similar patients to this went under HBO for 40 dives, and continued it, and they were surprised it didn't get better. And all it needed was a small procedure to let the flexor out, and once we did that, it was done. But and I'll show you that in a second too. These are the tough things that you can get from mouth or a hammer toe when they get ulcers on the tip of the toes. And I've seen a number of these in hyenas. And this also, as far as mechanical, sometimes these things will cause ulcerations on the bottom of the foot. What's happening is you get a retrograde effect from the toe hammering, you put pressure on the metatarsal bone, and you get these ulcerations or issues. This is a patient of mine that has flexible, and this is a procedure that we do. This is a procedure that we do in the office. We use you can only use on flexible hammer toes, and that's when you can take the toe and straighten it and manually. It's flexible. And this particular person, when I first saw them about a week before, this was inflamed, ulcerated. I could probe close to bone, and have them come in. If we put my antibiotics and schedule a flexor tenotomy. This is doing the flexor. This is doing the flexor tenotomy in the office. We go right at the sulcus, right at the base of the toe with a very small blade. It's a little bigger than a needle. It's called a beaver blade, 61 blade. And I've already known the person up obviously, and I just go down, feel the tendon, and dorsiflex the second toe, and that will release that tendon. There's 2 tendons that go to our toes, both the top and the bottom, and we're cutting the one that's going to the tip of the toe, which is causing the problem. Patients still can move their toes, not as they can't grab after this, but they can still move their toes. And there's still some function.
You guys are gonna do this in the office tomorrow? I saw you taking notes.
I love it.
So that's, in the end, that's what it looks like. It's a little, shoot. Anyway, it's straight. It's a very easy procedure to do in the office. And then. Then the other section is sometimes we'll have a patient who has a vascular disease and has trauma, and then has a wound from that trauma. This is a patient, I don't have a full case here, but this is a patient that came in, 72-year-old guy that fell at home and kind of fell like a week before he came in. He was walking around like this. He developed a very serious wound, necrotic wound. Right there. This is all open wound here. So normally, this kind of a fracture, this is a Lisfranc fracture dislocation. This is normally something that bring in pins in, plates, that type of thing, all the internal fixation kind of stuff to realign it. But we couldn't do that. There was a big wound there, and we found out quickly afterwards that there was that he had significant peripheral vascular disease. So I got Dr. Rosen involved, and he did the vascular procedure in the office. I believe in the office. I forgot all that, but anyway, we ended up then putting on because of the open wound and we're trying to get osteomyelitis, we put an external fixator on there to hold it in place and allow it to heal. We used a wound vac, and this wasn't smooth, but it got there, and he's now ambulating and doing fine. Probably about 4 or 5 months to do, and that healed with a combination of increasing vascular flow, addressing the vascularity, and then stabilizing it. That external fixator stayed on for 3 weeks.
Excuse me, sir. I'm gonna have to copy this sometime.
So, and that's then that's it.
Thank you.
That's the family. Thank you.
Thanks, Jay. Any questions? I mean, I have to say that I've been doing vascular surgery and critical limb ischemia and salvage for too many years. But what you just showed us was spectacular. And I thank you for teaching me something.
Thank you.
That was great. An artist there's not this kind of skill in a lot of places.
No, I will tell you, we're fortunate to have Jay in both Plymouth and Hyannis, and Jay's the guy that the podiatrists or have patients they don't want to deal with, they send them to Jay. So he's really tremendously talented, and it's part of this critical limb ischemia sort of center that we have of being able to kind of put the different skills together to save lives, and it works great.
That's the spectrum. It's early recognition of any wound that's not healing within a week or two should be evaluated for critical limb ischemia. And if a wound is being treated at a wound care center and it hasn't shown notable improvement in 4 weeks, it's probably an ischemic wound. So, and in diabetic, that timeline is just accelerating to days and weeks rather than weeks and months. So, but that was really spectacular. So, I'm the foreigner here. My name is Paul Gagne. I live in the great state of Connecticut. I was kidnapped by my wife many years ago from Massachusetts and brought down there. But I am a Red Sox fan. I am a Patriots fan. I am a Celtics fan. I am not a Yankees fan. And so, but as Dan kind of alluded to when he was talking, in spite of many years doing general vascular surgery over the last 8 or 10 years, I've had a long-standing interest in deep and superficial venous disease, and there's been huge strides made in treating this other half of the vascular system. And I can remember when I was a resident, going to my attending vascular rotation as a chief resident, saying, I've been reading this chapter on all these things we can do to help heal venous ulcers. And I think we should try this because I got this guy who keeps coming in with his venous ulcer. He was being admitted to the hospital for cellulitis and antibiotics. And my attending goes, I just want to tell you one thing. There is no treatment for venous disease. Put him in a wrap and send him out. And that was the nihilistic view of treatment for venous disease, advanced venous disease, at that point in time. I'm here to tell you tonight that we've made progress, and I want to share some of that with you. I want to show you how to recognize it, because we all know what an ischemic ulcer is. It's a wound that won't heal. We know what PAD is. You can't feel pulses. They have hypercholesterolemia, diabetes, hypertension, right? We learn that in our training. That's all part of our training. It's surprising how very little training goes on in venous disease, even in vascular training programs, until fairly recently. So what I want to do today is to show you a couple of the highlights, maybe talk a little bit about some of the procedures we do now that we weren't doing back when I had dark hair. And I wanted to just kind of let you see what this disease looks like, get you familiar with all aspects of it. Because it's not just a visible varicose vein that you can see on a leg, which somebody says they look ugly, can I get them treated? A lot of patients you'll find who have varicose veins, if you talk to them, you'll find out they actually have pain, they have heaviness, they get swelling in the legs, they're not happy. So you can actually impact their quality of life. But there's another whole side of venous disease that's much more severe that occasionally leads to amputation because of these long-standing ulcers and osteomyelitis. And so that's what I'm going to talk about for you now. Thank you very much. And please feel free to stop me if you have any questions. And I do need these, unfortunately. All right. So, that's not my talk.
Press it down, Aaron.
Go the wrong way?
Yep.
There we go. So, venous disease, thank you. Venous disease, not surprisingly, affects a large part of the American population because we all have veins. And in fact, it's actually more common than peripheral artery disease. So it's a disease that's often been untreated because, as Dan alluded to, in the old days we used to do strippings, right? And the way I would describe it, Dan, is we would put a stripper in, which is a little plastic tube. We tied the vein to the stripper in the leg through a couple small incisions. We tied a string to the door. We slammed the door, the vein came out, and then we walked out of the operating room. Not really. But that was essentially the barbaric nature of that procedure, and thank God we don't have to do it anymore. But what's really important is that it's not just about varicose veins. 6 million Americans will have skin changes due to chronic venous insufficiency and venous hypertension. 500,000 patients a year get new venous ulcers that need to be treated, and we know that there's a very high incidence of recurrence of venous ulcers, so even if you're lucky enough to get it healed, it's going to come back if you don't treat the underlying cause. Much to Jay's comment about treating the mechanics of ulceration. If you don't treat the mechanical problem, then it's going to recur. And then, as I said, more common than peripheral artery disease. We tried a lot of different things over the course of my career to treat venous disease, advanced venous disease. We tried a number of procedures with laparoscopes, we did ablation, we did sclerotherapy. What really was the first breakthrough was truncal vein ablation of the superficial veins. So we know about the great saphenous vein that runs down the medial aspect of the thigh and calf, the short saphenous vein on the back of the calf, and then there's a few cousins on the front here called the accessory saphenous veins. These veins get diseased by dilating. As you go through your life, you stand up through your life, the veins open, stretch, dilate. And so that pipe, which is carrying the blood up the leg, does this. And as it does this, there are valves in there, as you know, that keep the blood from going backwards due to gravity, since we're standing and sitting most of our life. And so as that vein stretches, the valves pull apart, and now you've got valve incompetence and reflux. The veins stretch and stretch as you go down the leg, and now you're pooling blood in your legs. You get those sensations of heaviness. Some patients get itching over the veins. Some people get redness in the skin. Some people get ankle swelling. There's very many ways that venous hypertension will show itself. It's not just those visible varicose veins that look ugly on the beach. There's a lot of different ways to see this disease, and that's part of the key, is in recognizing it in its different presentations. So as we talk about it, these are all the different ways that you're going to see venous disease, and you can treat this in many instances with venous ablation. And venous ablation is a small procedure that we do. Typically, as Dan said, it got pushed out of the hospital over 15 years ago. It is now an office-based procedure. The equipment doesn't exist in anybody's hospital anymore. And what you do is you make a venipuncture. So you essentially start an IV in the vein that you want to treat under local anesthesia. You put a little catheter inside the vein. You give some local anesthesia around the vein to anesthetize it. And then there's actually a few different technologies, but the most popular technology is what you see here on the left, and that's called an RFA ablation. You may have heard about it for other things in the body, such as the heart and such, which is used for arrhythmias. And what you're doing is you're cauterizing the vein, you're burning it. And you don't feel that because of the local anesthesia. We're having a conversation while this is going on. I tell the patients, it's their job to bring the joke book to entertain them while we're doing this. And so, while we're doing this treatment and we're shutting the vein down, what we're doing is we're turning it to scar tissue. And so we close the pipe so that the blood can't go backwards anymore. The patients ask me, well, what happens to my blood? And we know that it will immediately reroute into the deep system, which we know from ultrasound is intact and healthy. And so this is how we treat superficial vein reflux. And by doing this, we get to the underlying cause of their varicose veins, some of their swelling, a lot of their heaviness and discomfort in the leg, some of the redness that they may get at the ankle and calf, which is either venous stasis dermatitis or venous eczema. And then it can also help with wound healing. And so there are 5 things that I'm going to teach you today. The first one is that we can do vein ablations to help solve a lot of symptoms that patients have. The second thing is that not everything is about the superficial veins. It's usually the superficial veins in every instance are part of the story, but in many patients it's not the whole story because the deep veins can also be a problem. There's 2 types of problems that you can get in the deep veins. So we're talking about the popliteal, the femoral, the common femoral, and the iliac, okay? You've had a DVT. How does a DVT heal? Well, it's an inflammatory process. And the inflammatory process that heals a DVT results in scar in the deep veins, and you can develop a blockage. So I live next to 95 down in Darien, Connecticut, and I tell patients it's a 3-lane highway. When you get scar tissue in the vein, it's a 1-lane highway. And what happens to the traffic? It backs up back to New York, right? Well, that's what happens in your leg when you get scar after a DVT. The blood can't get through, you build up pressure in the leg, and you have all kinds of problems. So obstructive disease is a component of deep venous disease. The other part of it is reflux. And reflux can be the consequence of a DVT. That same inflammatory response can cause damage to the valves and dysfunction. But it can also be because we all got older. And as we get older, those valves will wear out and you'll start to see some reflux. And then you'll see patients who have severe chronic venous, right heart pressure elevation, right heart failure, pulmonary artery pressure elevation. They get pressure into their veins and they stress the valves for years until they just give up. And they get severe reflux. And they can present with some pretty severe venous hypertension. So what we've learned is that a lot of these patients who have severe venous disease, after you've treated their superficial disease, they may not get better enough. They may have outflow obstruction in the pelvic veins. It's typically the iliac veins, the common and external, and sometimes the common femoral vein. And this can either be due to compression of the vein by the adjacent artery. So you may have heard of the term May-Thurner syndrome or May-Thurner compression. It's something we all have to some degree. Because of the way our bodies are designed, the artery from going to the right leg actually compresses the vein going to the left leg. And so instead of having a 3-lane highway, you've got a 1-lane highway. In some patients, it results historically in DVT, but in many patients, it develops into a chronic venous hypertension that will develop into these kind of skin damages that you see down here. You've got an ulcer with brown discoloration wrapping around the leg, or an ulcer here with this red discoloration wrapping around the leg. Some people will just have the skin discoloration and no ulcer. Some people will have an ulcer with less skin discoloration, but they can all be manifestations of this. And then patients who have pain with walking, not arterial claudication, they have normal pulses, but their leg feels like it's swelling up when they're walking. That's called venous claudication. The way they feel better is they go home, put their leg up, and 20 to 30 minutes later, it's feeling better. This is because the 3-lane highway is a 1-lane highway, but they're increasing their blood flow into the leg when they're walking due to arterial flow, and it can't get out of the leg because the vein is narrow. And so stenting this can make that problem go away. So when you have a 1-lane highway instead of a 3-lane highway, The treatment in the veins up in the pelvis is to put a stent in. We'll talk about that in a second. This is an outpatient procedure. It's done under local anesthesia with light sedation at most. Complications are rare, and we see greater than 90% patency of 3 to 5 years in all the trials, and there's now been half a dozen published prospective trials to look at this. This has been around since 2006, 2007, but in the last 8 to 10 years, it's evolved in a remarkable way, so that it's now commonplace for a lot of centers. Oops, I'm sorry, wrong way. All right, so what we do for treating deep venous stenosis for these patients with advanced skin changes, wrapping around the leg, is we look with a venogram. So we put an IV in the vein, we shoot some dye up under X-ray, we look at the vein and see, is it narrow? Do we see the blood trying to get out of the leg through back roads rather than through the main road? And then we also put an ultrasound catheter in the vein. That's what Dan mentioned, intravascular ultrasound. So it's a small catheter we put up inside the vein, and we can see the size of the vein. And if it goes from a 3-lane highway down to a 1-lane highway or the breakdown lane, then we say, well, we've got an 80% stenosis, and that's what's causing this congestion in the lower leg and these symptoms. And we can balloon and stent that, and the patient's better. What's different than the coronary arteries and the peripheral arteries is because it's not a hardening of the arteries, it's not atherosclerosis. You don't see the same type of restenosis that you see in the arteries. And so these reconstructions tend to be durable for a long time with high degree of success. So here's a patient who I met a handful of years ago, and she had this discoloration that came on over about 3 years, wrapping around her leg. When you felt the skin, it felt like an orange, right? That kind of induration, right? You see the redness. This can either be called venous eczema if it's kind of patchy, or stasis dermatitis if it's kind of wrapping around the leg. And this is her venogram. Okay, so we're in the femoral vein down here. There's her hip, and the pelvis up here, and you can see the blood's going through. Don't really see an obvious narrowing here. You don't see any collaterals. You don't see the blood hopping off the highway and going to back roads. So this looks relatively normal. This is intravascular ultrasound. So this is the ultrasound catheter. This is the inferior vena cava. This is a wire coming up from the other leg. So we have a wire up both legs in this case. And you can see here that the artery is here. It's compressing, the artery is here, compressing the vein. Here's the artery from the other leg. This is the common iliac vein as we go from the umbilicus down to the top of the leg. And you're going to see this artery, this vein split here in a second into the internal and external iliac artery. And there we go. Okay, there's one, there's two, and here's the external iliac vein. So here's the artery on either side. And if you watch a second, I pause, you can see the vein is getting narrowed. And if you give me a second more here, you're going to see the vein get narrower, right about now. And you can see that that vein from that venogram is just this tiny little slit. The venogram looked pretty normal, okay? And then you come down a little bit lower. Oops, sorry. And you come down a little bit lower, and I just screwed it up. But the vein was normal down below. So what you see here is that little slit. Just below that was the normal external iliac vein. So the comparison of this is about an 80% stenosis in this patient's leg, causing the buildup of pressure, causing that stasis dermatitis, that induration, that redness. And so what we did is we put a stent in there. So we're back up in the vena cava. Here's the aorta and iliac artery compressing the vein, but not narrowing it. As we come down, we're going to see the vein, your common iliac vein here. We're coming down towards the top of the leg. And we see our stent here. And then as we come down, here's the two arteries that were pinching the vein before. And we see that narrowing is gone. And so this is about an hour and 15 minutes in the local anesthesia. Patients rest for about an hour afterwards, and then they go home for the day. And what happens is they'll tell you within a week or so, my leg feels lighter, it's not as heavy. It feels more comfortable, and then these skin changes Well, not the brown discoloration so much, but that redness, that inflammation tends to go away in the ensuing weeks. Now, it doesn't mean that we're doing an ablation or we're doing a deep vein intervention. It depends on what we find. On the ultrasound, we do a reflex study. We look at the valve function, we look for obstruction, and what we find a lot of times is they have a little bit of both. And so in order to control the venous hypertension, you have to treat the broken veins until you get to the point where you've done as much as you can do. That's when the patients get better. And some of these patients get essentially asymptomatic. Not all, but some do. So the third thing to remember is for those patients that have an acute DVT in the iliac or common femoral vein, or in the whole entirety of the popliteal vein, they have a high incidence of post-thrombotic symptoms. So this could be leg swelling, heaviness, pain with walking, and the best way to prevent the post-thrombotic syndrome is to remove the thrombus. And so again, this is a percutaneous procedure. There's about 20 devices on the market right now for removing thrombus from the leg. It's not like the old days where they went to the ICU and you drip lytic therapy into them to dissolve the clot. We now just suck it out or pull it out. And so it's a 1 day, couple hour procedure, and the patients go home and their problem is fixed. They go back on anticoagulation and they get better. And this is the best treated when you can get to them within the first week or two. So if you guys are seeing them in the office and they say, you know, my symptoms started yesterday, like you'd like to do, make that phone call, get them into somebody really quick, because the best way to get them better is to get them intervened on within that first 7 to 10 days. To get the best outcomes. They do have to be anticoagulated post-procedure. The fourth thing, so venous hypertension is a progressive disease, and I alluded to this in a minute ago. So if you've got some venous disease, you probably have more venous disease. It's like gray hair, right? You get 1, then you get 2, then you get 10, right? And it just keeps coming. And so venous disease tends to be progressive. But venous disease, the progression can be slowed down if you get rid of the broken stuff. So think about it, right? You got a clink in your engine, you're going down the road, clunk, 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 clunk. Well, you can go get it fixed and it goes away. Or you can ignore it until the whole engine blows, right? The same thing with venous disease. If you are having symptoms and you've got venous disease, get it fixed. Because what it does is if these veins aren't working properly, they start to overload their cousins and their neighbors next door. And now more veins start to be dysfunctional. And so as a result, there's a cascade effect. And so the best way to get ahead of that is to treat the problem early in this presentation rather than waiting. And I will tell you, and I know I shouldn't say this, women are much smarter about this than men. Women say, my leg hurts and I think it's my veins and they get it fixed. Guys go, you know, I know they look like big bags of grapes under my legs, and yeah, they ache a little bit, but you know, who cares? And they just go. It's just amazing. What can I say? We're stupid. Now, number 5, and this I want to emphasize, that it is a quality of life issue, right? Now you might say, well, you know, it's varicose veins, right? My legs may not look better, but you know, it's not going to impact my life. Well, actually, advanced venous hypertension, where you get swelling, pain, discoloration, in this multi-center study looking at patients with acute DVT and then the sequela of an acute DVT, so chronic venous hypertension and insufficiency, what they saw was the quality of life scores at 1 month was lower than patients with chronic lung disease and arthritis, and similar to patients with chronic angina. And at 4 months, their quality of life was similar to patients with chronic lung disease and arthritis. So we think of vein disease as not being life-threatening. We think of vein disease as not being limb-threatening, although occasionally it is. But in fact, it really is something that's a real drag for patients over time in their day-to-day living. And the treatments are fortunately minimally invasive and low risk. And so I think it's something that in the trade-off between chronic pain, discomfort, and happiness, it's an easy equation. And the outcomes for interventions for the venous stent procedures is that 70 to 80% of patients who had pain as part of their presentation as a result of their deep vein occlusive disease and were stented, you can see that 3/4 to 80% of them get better. Their ulcers heal, and about half of them, their swelling gets better.
We don't always take any plates, like if they're off the table.
Give me about 10 minutes.
Oh, yeah, no worries.
Yep. And so, so there's a high level of success with these procedures, both superficial and deep vein interventions. There's very low morbidity. There's very little to almost no mortality. Those are almost a never event, and they have long-term success. So now we're gonna have a quiz, all right? Because I figured, you know, after sitting here absorbing, we're gonna try to feed back, okay? So we're gonna look at this leg, okay? So this is what we call a clinical seat 2 patient with varicose veins with some maybe itching and throbbing in the veins. Thoughts on what you might want to do for this patient, and you guys don't get that way yet. Vein ablation versus stent. Huh?
I would prefer statin
Well, that's pretty good. Anybody want to take a guess? Vein ablation versus deep vein stent. I'm going to say vein ablation. All right, because I know the answers. So you don't see any skin damage here. You have localized swelling at the ankle and varicose veins. So if you treat those varicose veins, which is the superficial veins, we call the axial veins, as they run up and down the leg, with an ablation, you're likely to get rid of all the pain and all the swelling. This is a patient who calls clinical seat 4A. And so you can see here, you got some varicose veins. You got this brown discoloration. It's not really wrapping around the leg. It's kind of focal on the inside of the leg. No ulcer. Do we do an ablation or a stent? Who said stent? So that could be right. You could do either, I think, in this case. So a lot of people would treat the large bulging varicose veins, but if this doesn't get better, then they're going to do a stent. So you would maybe stage that one. But you're on the right direction. The more severe disease, the more likely a stent. So what do you got here? Circumferential skin changes, skin breakdown, inflammation along the leg. This is inflammation, not infection. Okay? What are you thinking here? Yeah, so you would be thinking stent, but if there's superficial disease, you probably would treat that as well, because you got to address all the venous hypertension. Okay? The one thing I would say is there's a group of patients who are treated over and over again for cellulitis, and they get better, then they get recurrence, and they get better, they get recurrence. Somebody who has recurrent cellulitis in the lower leg probably has venous disease that needs to be addressed. So that's an important referral thought for treatment of their venous disease if you're seeing recurrent cellulitis. So we would evaluate the superficial and deep and treat the deep, and then if there's reflux disease in the superficial, we would treat the superficial for this patient. So in conclusion, symptomatic venous disease is common, more common than PAD. It negatively impacts your patient's quality of life in a significant way. The treatment of deep and superficial vein disease is low risk and quick recovery. Whatever they have done, they're up and walking that day, so it's not a long recovery period or disability, very low complications. We do that, vascular surgeons, that's in our bailiwick, and it's largely an outpatient local anesthesia procedure plus or minus local sedation. So if you send a patient to us for venous intervention, tell them to buy a joke book, bring it along with us, and talk during the procedure. And thank you. Any questions? Okay. So this concludes our presentations for tonight. You've been great guests for the Vascular Health Forum. And I know all of our doctors are open to questions if you have any. If not, questions? All right, well, thank you. You've been great. Safe travel. We'll be doing this again, so please share this with your friends and colleagues. Hopefully you learned something valuable tonight, and we'll reach out to you with the survey just to kind of get your feedback. So thank you.